Welcome to this series of interviews with the giants of thoracic surgery. My name's Joel Dunning and we're here at the SCTS conference in London, UK with Professor Rob McKenna. Professor, you're Professor of Thoracic Surgery at the University of California. You're the Chief of Thoracic Surgery at the Cedars Sinai. You've written a book on the anterior approach for VATS lobectomy and have by far the largest experience teaching this technique which you invented. And you've taught a vast number of surgeons around the world in this technique, but most people would be content with just that as a career, and which has been amazing. But you've also been the principal investigator on many trials. I'd like to talk through a few of those, some more recent ones such as the Z0030 in adenectomy, but also you're a principal investigator on the NETT trial. You've written 120 papers on lung volume reduction, and you've just given the Tudor Edwards lecture here at the Society about lung volume reduction. So we'd like to talk to you about this first of all. I wonder if first of all you could tell us a little bit about the background of the NETT trial, what it showed, and where we are at now as a result of the NETT trial.
Great. Well, in the early 1990s, Joel Cooper proposed doing an operation for patients with severe symptoms despite maximal medical management in the treatment of their emphysema. He recognized that if patients had a heterogeneous pattern of emphysema, meaning that the top was no good and the bottom was much better, that you could resect a non-anatomic portion of the top of the lung, and that resulted in significant improvement in the pulmonary function test and the quality of life for patients. That started to catch on. There was a lot of enthusiasm for that, but the government was concerned that there wasn't enough data to prove that it was safe and effective, and the government was concerned about how many operations they would have to pay for. So the NIH and Medicare sponsored a trial, a randomized prospective study looking at maximal medical management for patients with severe emphysema. The patients received either just maximal medical management or that plus an operation. 17 different centers were involved in the study, and the ultimate results of the study were that for properly selected patients, lung volume reduction surgery improves quality of life, pulmonary function, exercise ability, and even survival.
And those are real, actual, tangible benefits, aren't they? And you saw these people in their clinics. People really did get very significantly better from lung volume reduction surgery, didn't they?
Those benefits are huge. When you talk to someone with severe emphysema, their stories are very compelling. Patients have shortness of breath in the shower. If they try to lift and carry anything, they're severely short of breath. If they try to bend over and lift, basically, patients with severe emphysema can be prisoners in their own house. Things that we just take for granted, being able to go shopping, they can't do because they're too short of breath.
The NETT trial gave us some good categories of people that particularly benefit from this type of surgery, doesn't it?
Right. The best group of patients for this are patients with a severely heterogeneous pattern of emphysema. That means that the top part of the lung really is non-functional. It takes up space, it's hyperinflated, and really doesn't provide any ventilation or oxygenation. And the lower portion of the lung is much better. So it's important in the evaluation to identify those two characteristics, that the top is no good and the bottom is much better.
Now I know a lot of surgeons that have a lot of concerns about doing lung volume reduction surgery, and so what criteria do you use for selecting your patients? We've obviously got the NETT criteria, 20 to 40% FEV1 and DLCO. Do you stray out of them much, or do you stick pretty much to them? And what other criteria do you think are really important?
Well, it starts with the patients and taking a history. Patients need to be symptomatic despite maximal medical management, and it's emphysema that really has to be their problem. When patients have significant bronchitis, meaning that they cough up a cup of sputum a day, that is not something that is ideal for lung volume reduction surgery. So it's a problem with severe emphysema, and the symptoms in daily life I mentioned before: trouble in the shower, trouble walking, trouble carrying and lifting things. So it starts with that. Patients then have pulmonary function tests that need to show severe obstructive disease, so that the total lung capacity is significantly larger than usual, the residual volume is significantly enlarged. Typical average numbers for total lung capacity would be 140% of predictive. Typical numbers for residual volume would be more than 200 or 250% of predicted on the average. The FEV1 is in the range that you mentioned, 20 to 40% of predictive.
Would you push that much lower? If someone had 15%, do they start to get very high risk?
It increases the risk to some degree, but it depends a great deal on the clinical setting. So that if a patient otherwise is in good shape, they're not too old, and they're very motivated, and they have the perfect pattern of heterogeneity on the CT, they still may be a very good candidate for the operation.
I like what you said earlier, that everybody goes through a rehabilitation program, and that really shows their motivation, doesn't it?
The rehabilitation is important for that reason, yes. It shows their motivation, and for patients who are severely incapacitated, it gets them in shape so that the operation is safer. Patients come to me and they tell me, oh yes, they'll do anything that I say, but they need to prove it to our pulmonary rehabilitation people. So the patients go to the rehab. It's not just that they sign in for 5 weeks and then they're all set. They need to go there, work hard, and convince our pulmonary rehab staff that they are motivated and that they are prepared to do what it takes after the operation to do well.
And what exactly is your rehab? It's 5 weeks every single day for an hour, or how hard is it?
It's roughly 5 to 6 weeks. The patients go at least 2 to 3 times per week. I tell them that they really need to be athletes in training every single day the rest of their life. Meaning every single day I want them walking, on a treadmill, on a bicycle, doing something to maximize what they're able to do with what they've got. So the features of pulmonary rehabilitation would include an educational component where they learn about emphysema, they learn about inhalers and medical management. A very important part of it is the exercise. I want the people in pulmonary rehabilitation to be mean, nasty drill sergeants to the patients. I don't want them to say, okay, you've done 2 minutes on the treadmill, congratulations. I want them pushing hard to get short of breath. It does not damage the patients. They need to be on the treadmill. They need to deal with the anxiety of being short of breath and push hard. Ideally, they should get to the point where they can walk 30 minutes on a treadmill without stopping.
And what tests would you regard as mandatory before you took someone to theatre? Obviously we've got a CT and a chest x-ray, but does everyone get a VQ scan and ergometry?
I think radiologically, the chest x-ray, the CT scan, and the lung perfusion scan all are important. For most patients, the chest x-ray will tell you if they're a good candidate or not for the operation. Probably 80% of the time we can tell from a standard chest x-ray. CT scan is done to confirm that. Occasionally patients have lung nodules. CT scan can see and define those better than a chest x-ray will. And there's a small group of patients who are not fully evaluated by the CT and the chest x-ray. The lung perfusion scan is important because it's a physiologic test. It shows us how well different parts of the lung are functioning. So there are some patients where I'm not sure based on a chest x-ray and a CT, but the perfusion scan clearly shows that the upper portion of the lung is non-functional. So those patients would be still good candidates for an operation.
And the exercise capacity, do you formally test them all, or is it more of a taking the history?
The exercise capacity is both. We take their history, we encourage them strongly to go to rehabilitation, to walk, bicycle, or be on a treadmill. We do a 6-minute walk test prior to the operation as a baseline to see where they are.
So let's move on to the operation itself. Obviously initially there were lots of ways of doing it, open stenotomy, one side, two side, but maybe you could perhaps go through for us a little bit your own personal current technique in a heterogeneous patient with upper lobe emphysema bilaterally.
Well, we routinely do bilateral thoracoscopic lung volume reduction surgery. The operation inside the chest is the same. It's just a different incision used by a variety of surgeons. I think whether you do a median sternotomy or bilateral VATS, the patient selection and the operation are the most important things. I feel that you can do the same operation either by sternotomy or with bilateral VATS. The NETT showed that the outcomes were comparable, the benefit was comparable, the risk was comparable, the length of stay was slightly shorter, and the cost was slightly less for VATS. Another advantage was the recovery was a little bit quicker, so that a higher percentage of patients were in their home recovering from the operation rather than needing to be in a skilled nursing unit at 30 days after the operation if the operation was done by VATS rather than a sternotomy.
And I suppose one of your first steps is to get that lung decompressed. I suppose VATS, it's right up against the camera and it never comes down, does it?
That can really be challenging, no question, because these lungs have great compliance, so they fill up with air well. They have poor elastic recoil, so it does not decompress very well. Some surgeons would use CO2 insufflation. I think the best thing to do is simply make a hole in the portion of the lung that is to be resected. And in proper candidates, there is such severe emphysema in those parts of the lung that you simply make a small incision into the pleura for that area, and the lung in that lobe will very quickly and completely decompress.
And new surgeons coming to this, or people that don't do it very often, certainly I'd be very concerned of knowing exactly how much to take out. Is it better to do too much or too little, or what are your recommendations for how much to take out?
Sure. The answer to that is during the operation, immediately post-op, you always wish you took a little bit less and maybe the lung expanded better and filled the chest, and shorter duration of an air leak post-op. And longer term, you wish you would have taken out more. But in general, the technique involves taking out 60% or 3/4 of the upper lobes on both sides. For example, on the right side, we would start the staple line anteriorly at the junction of the anterior segment of the upper lobe and the middle lobe. The staple line then goes obliquely from anteriorly to posteriorly and stays out of the fissure with the removal of about 3/4 of the upper lobe. The lung, of course, is very soft and very difficult to operate on. It's easy to tear the lung, so it is very important to set up the operation well and sequentially fire the staples multiple times.
And what stapler do you use? I believe you use buttressed staple guns.
Most surgeons will use staples with a buttress, so we use bovine pericardium, but there are other buttresses available. I like to have two different staple handles on the table, so my scrub nurse is loading one as I'm firing the other one, so that makes the operation pretty expeditious.
Yeah, and I think you mentioned a bit earlier that you just keep out of the fissure, because that can be quite a problem if you get in there.
Many of the patients that we see have subpleural emphysema, and when you look at the anterior and posterior segments of the upper lobe in the fissure, it really looks like there's a little blister or a series of blisters on the surface. When we staple through that tissue is so thin that it really does not hold the staples even with the buttress material. It is difficult to suture, and I think those patients tend to have a longer air leak. So we tend to make the staple line just parallel to the minor fissure and posteriorly to the major fissure as we march across the upper lobe.
And I suppose air leak's one of those things that just comes with the territory, doesn't it? It's quite common.
They do. As hard as you try to eliminate air leaks, 90% of patients after LVRS will have an air leak. So we put in chest tubes and we wait.
How many chest tubes do you put? Several in?
I usually put 2 chest tubes on each side.
And is there any good tips for minimizing air leak? Just a nice sequential stapling, or there's no magic bullet?
Oh, I think there is some magic to it. I think it is very important to be gentle with the lung tissue. We line everything up. I think it is important to put the stapler across the tissue and do not angle obliquely into it. so that if this is the lung tissue, we make sure that the staple lines up with the lung tissue and we fire it. We keep holding the lung in that position and sequentially fire it that way. If the stapler is pointed obliquely towards the lung parenchyma, then you can tear the lung. I think it is also important to remember that the lung is fixed immediately towards the hilum so that the stapler stays closer to the hilum. Laterally, the lung is much more mobile, so we bring it over to the lung from laterally rather than pulling it away from medially.
Okay, so is there anything post-operatively that you pay special attention to get these high-risk people that sometimes on oxygen back up on their feet? Are you very aggressive getting them up?
Absolutely. I tell them that I do the easy part. I do the operation. They have all the hard work to do post-op. So that means get out of bed the day of the operation, get up and walking the next day. They will have many tubes and catheters. There will be an art line, peripheral IV, epidural catheter for pain control, Foley catheter, 2 chest tubes on each side. So they have many tubes and catheters to deal with. Our nurses are used to that, and I tell the patients, doesn't matter, they've got tubes and catheters, they have to get up and get moving.
So they'll be standing up day one and then moving around after that.
Right.
And you prefer epidurals to paravertebrals or epipleural catheters? Yeah.
I think epidurals help patients a lot with this operation. They're not perfect, but in general, they do a good job and they keep the patients comfortable. So we try to eliminate tubes and catheters as quickly as we can. Usually the day after the operation, the art line is removed. Hopefully the intravenous is removed the morning after the operation. The chest tubes need to stay until there's no air leak. When there's minimal drainage from the chest tubes, then we cut the chest tube, or we cut the tubing between the chest tube and the drainage system and put a Heimlich valve on there. So we disconnect the patient from as many of these tubes and catheters as we can quickly so they can get up and get moving.
Yeah. So you showed us today the amazing benefits, we already talked about it, so, and yet the numbers are dismal, aren't they? They're virtually non-existent in the UK and small. What are we doing wrong, and do you think we can ever get to a stage where people might benefit from this? What can we do as surgeons?
Well, I hope we can. I think there are many things done well with the NETT, and there are some things that were not done as well. Medicare was concerned about the cost, so they wanted us to prove that the procedure was safe and effective. They stopped paying for the procedure in December of 1995. In conjunction with the NIH and Medicare, the randomized prospective study known as the NETT was performed. That's the first time that cooperation has happened between any group of physicians and Medicare and the NIH. So I think that's a great model for the future. I think a big important study was accomplished through that cooperation, and it clearly showed that the procedure was safe and beneficial to patients. And I think that concept is probably a very relevant concept for the current economic situation, the current crisis with healthcare. We need to look at treatments to see what is really safe and effective and what is reasonable. However, the corollary to that is that we have to make sure that those aggressive treatments that are clearly safe and effective are indeed offered to patients. Unfortunately, the first paper with results from the NETT identified the patients at high risk for the operation, and too many people interpreted that paper as saying lung volume reduction is too risky and has too high a mortality rate, so patients should not be offered the procedure. Quite to the contrary, we identified people who were not candidates for it, and the study showed very clearly the benefit for the procedure. So we need to get that message out to patients, we need to get that message out to internists and pulmonologists so that their patients can be treated optimally.
So there's a new paper just coming out. It's going to be another game changer in thoracic surgery, and perhaps you, better than anybody with the experience of NETT trial, can advise us as to how to address this properly. And it's lung cancer screening. What impact do you think this is going to have in the US and worldwide, and how, as we as thoracic surgeons, can we make sure it's managed properly and to the benefit of patients?
I think that's a great question. I think we can learn lessons from the NETT so that we hopefully handle this better. Clearly there is a benefit for screening. Of the 4 top cancer killers, lung cancer is number 1, and it's the only one of the top 4 for which there is no screening that's currently approved. The NIH just announced that their screening study showed a 20% mortality rate in lung cancer when screening was done by CT scans. We need to wait to see the paper actually in publication to learn all the details of it. But it looks like screening should be done. We have to be careful in the way this is rolled out to the public. If you do CT scans on patients over 50 with a 30-pack year smoking history, 1 out of 3 people will have a nodule in the lung. Maybe 1% will have cancer. So screening does not mean that every nodule should be taken out of every patient. So I think it is very important for all the societies, the oncologic societies, pulmonary societies, and the thoracic surgery societies, to get together as they are to come out with a statement of how this should be responsibly rolled out for the public. We need to make sure that it is not mishandled, I think, is the way the information from the NETT was mishandled. This is important. This can save many, many lives every year in the United States, and we need to roll this out to people in the United States and the rest of the world to help them.
And I suppose it's handling that huge new number of nodules that's really going to impact thoracic surgery practice. Do you think we as surgeons should be following these people up, or do you think we should be leading how this service is set up? How are we going to deal with all these thousands? Can you just take this out?
Sure. Well, I think surgeons are the ones that need to step up and take care of this, because we have a huge advantage over radiologists and pulmonologists and oncologists. That's where we live, that's what we do. We see nodules on the CAT scan, we take them out, and we get that feedback as to what those nodules are. We are in a better position than the other specialties to truly know the likelihood of that nodule being a cancer. I think it is very important that thoracic surgeons are involved in this process of evaluating nodules to decide who should have an operation and who should not have an operation.
So just changing the subject again, you were principal investigator on the Z0030 trial. It was a trial of lymph node sampling versus adenectomy. There's quite a few intricacies in this study, and I suppose if you just scan the bottom line, it says give up, you don't need to do adenectomy anymore. But could you maybe describe the study a little bit and tell us what your take-home message is from that study?
I was one of the many investigators on the ACOSOG study that randomized patients to either have lymph node sampling or lymph node dissection for lung cancer. And the bottom line to the study was that there was no difference in survival in patients who had sampling versus lymph node dissection. Previous retrospective reviews had suggested that perhaps there was benefit to the dissection, but this study did not show benefit for dissection. The study does not mean lymph node dissections or sampling should be abandoned. It simply means that as long as a good systematic sampling is done, that the survival seems to be just as good as a lymph node dissection. I think every lung cancer operation needs to have lymph node evaluation as part of the operation.
And yourself, in your own practice prior to VATS lobectomy, I believe you do a very extensive mediastinoscopy, virtually taking out the station 7 node. That's maybe perhaps how we should be going at it, do you feel?
Well, I think mediastinoscopy is a great operation, and in particular the video mediastinoscope greatly enhances our ability to do a very complete, effective mediastinoscopy. We do mediastinoscopy for all patients that have more than a T1N0 tumor by PET and CT scan. And of the T1N0 patients, if the patients have a poor performance status, are really old, if there's something that we're concerned about, their ability to tolerate an operation, then we would do a mediastinoscopy in those patients as well. The video mediastinoscope is one of the few toys that we have that makes an enormous difference in our ability to do a good, complete operation. With mediastinoscopy, we start by dissecting down along the plane of the trachea. We go to the level of the pulmonary artery and mobilize the pulmonary artery. We dissect along the medial aspect of the left and right mainstem bronchus. We clear out all the subcarinal lymph nodes so that when we're done, you can see both mainstem bronchi and the esophagus behind it. We put Surgicel in that area. When we do right VATS to take out the lung tissue, we can see that Surgicel is sitting right on the superior aspect of the inferior pulmonary vein. So we really have cleaned out that space pretty well. We then start moving proximally and see the azygous vein and the superior vena cava. We take the fat and all the lymphatic tissue away from the superior vena cava and clean out almost all the tissue from the pulmonary artery right up to the innominate artery, from the right side to the left side. When we're done, we can see the superior vena cava well exposed. You can see the pleura, and through the pleura you can see the right upper lobe. It really does not take much time to do that, and the video scope allows me to do a tremendously better operation than we could previously with the old-fashioned mediastinoscopes.
So, and I suppose all that takes about an hour or so. So the concept of a quick pick 3 nodes out and get out is really not acceptable in the modern era, would you say?
Well, it takes about half an hour, but
Yeah.
The results that Alex Little published 6 years ago are just incredibly embarrassing. The SEER data from the American College of Surgeons show that just under 50% of mediastinoscopies even yield a lymph node. That number is just horrendous. I don't understand how you can do a mediastinoscopy without taking out lymph nodes. You should be able to see all the different areas and at the very least sample several different areas. But the video mediastinoscope, I think, really allows you to do essentially a lymph node dissection with this scope.
And just a little question, my own interest really. You've done this fantastic mediastinoscopy. You found one little tiny microscopic area of N2 disease in the station 7. Are they no longer a surgical candidate in your practice, or how do you handle these people?
When we find mediastinal lymph nodes involved, as we do mediastinoscopy or an anterior mediastinotomy, then we routinely send patients for neoadjuvant treatment. So that would mean, in my practice, that they would get neoadjuvant chemotherapy. After the neoadjuvant treatment, we reassess them with a PET-CT, a brain MR, and a pulmonary function test. We actually have looked at our data in patients that have an isolated metastasis less than 2 millimeters in diameter. And our data actually showed no difference in the survival. So you could argue to go ahead and do the resection. However, when the mediastinoscopy shows mediastinal nodal metastases, our normal practice is to give neoadjuvant treatment and reassess the patients for possible resection.
And that reassessment, that wouldn't involve re-mediastinoscopy? Would that be an EBUS assessment, that it's all cleared out?
It depends on what was done before and what we see in the follow-up scans. Because we do a pretty complete mediastinal node dissection with the mediastinoscope, there's not much left there. When we repeat the PET-CT and find an abnormal area, we use whatever test is the best approach to try to get a biopsy. So we do EBUS. If the patient had EBUS to start with, then the follow-up could be either an EBUS or could be a mediastinoscopy. If the mediastinum seems to be clear, but then an R10 lymph node along the right mainstem bronchus lit up, then we could do EBUS to biopsy that. So it depends a little bit on what was done before. When you have done a node dissection by thoracotomy or VATS, to do a repeat mediastinoscopy can be very challenging. When just a few lymph nodes were taken out and found to be positive, so nothing further had to be resected, or when the initial staging biopsies were done with EBUS, then certainly mediastinoscopy can be done.
Great. So, just finally, one of the interesting parts about the Z0030 was a comparison of VATS lobectomy versus open lobectomy. The interesting results were not only was VATS better in terms of fewer bronchoscopies, the patients staying in hospital less, but actually it was quicker as well. What would you say the take-home message is from that analysis?
Well, I think there are many studies from around the world that show benefits to minimally invasive lobectomies. We've now done over 2,600 lobectomies and segmentectomies by VATS. I think it is a great thing for patients. I think they hurt less, the length of stay is less, they recover more quickly. So I think there are great advantages to patients to having a minimally invasive operation. It has to be a full, complete cancer treatment. So it should not be a glorified wedge resection. The artery, vein, bronchus, and fissure need to be individually ligated with the staples. My preference, even though the 030 study showed no survival benefit to the no dissection, my preference would still be to do a no dissection because the dissection is easier and quicker. When you dissect along the superior vena cava, along the pericardium, along the trachea, and take out all the R2 and 4 lymph nodes, that's done in one package. It's simpler and easier, and I think less bleeding when you do a no dissection. So the complete cancer treatment needs to be done for the patient. And I think when surgeons can do that with minimally invasive surgery with low risk to it, then I think you're doing the patient a great service.
And just finally, for those surgeons out there that don't do VATS lobectomy, you've got a fantastic series of resources. You've got books, DVDs, and things about the anterior approach. But for a surgeon out there who wants to learn it, do you think they can just watch the videos and then try it themselves? Do they really need to, or do they really need to come in and buddy up with somebody with experience? What would your recommendations be to someone wanting to embark on?
I think that all those things are helpful for thoracic surgeons to learn how to do minimally invasive lobectomies. There's no reason to reinvent the wheel. Plenty of people have done that. There are different approaches. I think there are many ways to acquire the skills to do it. There are courses regularly offered where surgeons can go watch the procedure being done. I think it oftentimes helps to take those courses twice. To go the first time to see the general setup and techniques for how to do it, to go back home and struggle for a while, and then come back 6 months or a year later with a whole new set of questions at an advanced level to discuss where it was difficult or challenging. For now, our books out, we just published an atlas where you can get books that show step-by-step how to do the procedure. You have videos to look at to learn the procedure. I think you can hire a younger partner, a new associate, who comes from a training program where that person has learned it in their training. So there are many, many different techniques for how to learn how to perform the minimally invasive operations.
Well, it's been an absolutely fascinating insight. We've crossed 3 different whole subjects, and I'm sure we could do another 20 if we had time, but that's been great, and thank you very much from CTS NETT, and from myself, just like to say thank you very much indeed.
Great, thank you.